and welcome to this wonderful discussion that is going to be for next 45 minutes or so. The topic is as hot as it could be. It is myopia, right? We are going back to the basics. I keep saying that when I was studying, if somebody told me that in 2021 you would have so many sessions on myopia, I would never believe that. But that's how it is. Everyone is talking about myopia, and so we are. We have a wonderful panel of experts today. Let me start with introducing the lady first. We have Mrs. Lakshmi Shinde. I think introducing her in an OCI event is kind of a bit embarrassing, but still I'm going to do that. She is the CEO of OCI. And apart from that, she has a private practice. She works with IACL as a global educational manager there. And so many different hats she wears. Sometimes she forgets how many hats she actually has. So welcome, Lakshmi. This is in a way your event, but I'm going to be the moderator, so it's going to be fun. We'll keep playing table tennis, right?
Yes.
And Lakshmi is joined by three wonderful, good-looking men, three good men. We have Mr. Yashwant Sahuji. Again, no need to introduce him. A good friend, a good colleague, a good practitioner. He's, I would say, one of the pioneers in contact lens practice as well as contact lens education, has been a key opinion leaders for many contact lens industry, and specialty contact lens practices is forte. So welcome, Yashwant. Good to have you once again.
Thank you.
Moving across, we have Dr. Vishwanathan. Vishy, good to see you after some time.
Thanks, Nilesh.
He is an expert in optical dispensing as well as clinical optometry. Currently working as assistant lecturer at the Elite School of Optometry, Chennai, and he is also managing the Myopia clinic at Shankar Nethralaya. So we're going to have some good insights from Vishy about how he's managing, the Myopia clinic and his experience there. Last, finally, the youngest one. I thought I'll introduce the youngest one, the last, and I'll take the liberty of calling him the most handsome among us here. Pawan. Good to have you, man. So Pawan is a research scientist in myopia. I think he's very passionate about myopia. Completed optometry about a decade ago from the Bausch & Lomb School of Optometry. Then did his PhD and postdoc also. I think he was in Singapore for his postdoc. And currently he is a scientist at BHPI. At the same time, he also has a myopia clinic at LV Prasad Institute. I hope I have introduced you guys correctly. It could go on and on, but at least I've made a correct introduction of all of you. So guys, welcome. And all those who are listening, if you have any comment or any questions to these wonderful panelists, please feel free to type those questions on the Facebook, and we'll take the most relevant and interesting ones. Good. So let me start with a very, very simple, basic, or I would say a straightforward question. And because Pawan is the youngest and the most handsome, I think I'm going to start with him. Pawan, there's a lot of talk about myopia going on, and some people, like even initially, I was one of them, who did not believe so much about it, especially when you look at India, kahan hai yaar itna myopia and things like that, right? Now you are a researcher, you have enough data. You also published a paper on that, and I'm an advocate of your paper. Actually, we've taken that paper in IACL research updates, etc., etc. So what I want to understand from you is it really a big issue as it seems, or is it hyped? It's a common optometrist's question.
I think this is the intense question to start a panel discussion. Directly jump on to the most intense bit. So the straightforward answer to that question is, I think, yes, it is a concern. It is a clearly public health problem. Given the numbers, I mean, we estimate that about 50% or approximately 48-50% of them would be myopic by 2050. So which means like 5 out of 10 would be there's a need for them to wear spectacles or any refractive correction. Same is the case with India as well. That's what our paper. Thanks for your advocacy on that. So yeah, we say that now. Will just the numbers make a problem much bigger? I think there's much more than the numbers itself. Right. So we say that, out of 100, 20 of them will have high myopia. Now today somebody has -1 does not mean that person will be -1 forever. So -1 might go to -2, -3, and by the time that person gets to the adulthood, that person might have high myopia and sort of pathologic myopia, visual impairment. Now that numbers needs to be counted as well. So 10% of them are likely to have high myopia and greater risk of visual impairment at a later life. So putting things in perspective, whoever says that it's all hype, it's all created, I think we have to understand that what we see is only maybe the direct cost. Okay, -1 today, I get a pair of spectacles, it's deal done. But what we don't see is the indirect costs, the socio-economic status or the economic burden for the individual, and the complications that might trigger in because of myopia, and which might eventually take them to the visual impairment level. So the answer is yes. Whoever is saying that, maybe rethink before you say that this is all just a hype and it's all created.
Yeah, so something like what I did, right? I also recalibrated my brain, and I'm also taking myopia seriously after the initial resistance. I think I'm going to come to Vishwa first, and then I'll move to Yashwan. So Vishwa, your myopia clinic is based in a tertiary center in Chennai. So what Pawan is saying right now, are you seeing the reflection of that in your clinical practice? How would you weigh that?
Yeah, before I answer that, I'll just tell you a small statistics that we did when we went for the school vision screening. When we did the we go for urban as well as rural school screening, also tribal. See, when we look at the prevalence of the tribal and the rural, it is definitely not much. It's about 0.3 in tribal and 1 to 2% in rural. Okay. But when we look at the prevalence in urban, either private or public schools, it differs drastically. For example, in the public schools, when we did pre-COVID, it was around, say, less than 5%. Okay. When we did the private schools, it was around 18%. So it varies drastically between even urban public school and private schools. We recently went to the urban public school where I said it was less than 5% pre-COVID. And currently it is about 20% even in public schools. So you can imagine the impact of COVID on these kids. Okay, so that is exactly what I wanted to highlight here before even I move on to the hospital base. See, ours being, as you said, tertiary, we have been myopic kids for quite some time, for some years, in fact. But what we have been doing in the last 4 or 5 years is we felt the need for systematically document, some of the measurements, including axial length measurements. That is after, all these prevalence data, global data. We felt the need for documenting this so that, we understand and we follow them up. And in case if we see some change in these kids, intervene them. So that is what. So to answer your question, yes, to add, the value to all of these things, the straightforward answer is yes. Okay. That we are seeing a change in numbers.
Okay, cool. Coming to Yashwant, I mean, Yashwant is representing private practice here. So Yashwant, what are your thoughts on what you see in your practice?
Yeah, so Nilesh, actually, I don't think any optometrist would dispute that myopia is on the rise. The disagreement or the point of contention would be whether it is increasing to that level which the researchers are pointing out as. Now, what I've realized is, being a private practitioner, my job is to manage the myopia better. And I would rely on guys like Pawan and Vishwa to give me the statistics. And I really don't know whether it is increasing to that level, but if researchers all across the world are coming to the same conclusion, it has to be true. But one good thing that has happened because of all this is we've started looking at myopes in a slightly different way. We've modified our examination protocols for all the myopes. And we've realized that these things do cause the complications. Initially, when I came to know about the complications, and I said, okay, hota hoga yaar, I don't know kitne logon mein hota hai. Until one case changed my outlook. He came and sat in front of me And he did not speak a word for about a minute. And that silence was really deafening. And after a minute, he said, 3 months back, I was perfectly normal guy. And now I cannot see anything. And the doctor said, this is because of myopia. And that changed my complete outlook about how to treat a myope, you know. And then I went back into my records and I saw so many myopes going blind. Those, of course, were high myopes. And myopia is a real threat. The percentages, we have to rely on guys like Pawan and Vishwa to give us the percentage. So we need to take myopia control very, very seriously.
Okay.
And I like the point which Pawan also made, you know, it's not about the myopes, but it's about the myopes who are constantly increasing. I mean, that's going to be a different bracket altogether, whom we need to tackle myopia at really aggressively.
So would you also say you're seeing probably more number of patients, or you haven't really thought about it?
No, the numbers are definitely going up.
They are going up.
I said the percentage wise, I really cannot comment.
Yeah, that's okay. No, I'm just asking specific to your practice.
Numbers are going up. Definitely myopia and astigmatism, both numbers are going up.
Okay. So I think all three of them are saying the same thing. And I'm going to come to Lakshmi. And the question for her is slightly different. I mean, you know, recently we saw a wonderful video about, and this task force, you know, that OCI had commissioned, including Lakshmi and all these gentlemen, and we have few more people. I think that video is very good, very easy for, you know, people to understand what myopia is and so on. And it was also inaugurated by Nitin Gadkari ji and got a very good mileage. So I have a question for you, Lakshmi. Why did you think of doing this in the first place? Kyun kiya video ye?
It is the answer to the same question, Nilesh, that you asked. Do you think myopia is big? Okay. So I think all the three experts have answered saying, yes, it is real, first of all. It is not something made up. Statistics are not made up. WHO will not, an organization like WHO at an international level will not look at it unless and until it's something really real.
True.
Okay, so I think what we as a task force, you know, discussed is, yes, it's all fine. I mean, you know, among optometrists we can discuss, but how do we get this information out to the public so that we kind of sit up and say, okay, this is something that, you know, that's happening, that's real. So I need to get my eyes examined. I need to get my kids' eyes examined as early as possible. If, you know, if parents are myopic, we need to get the kids to an optometrist or an ophthalmologist as soon. So that was something that we were discussing. You know, we said, how do we get this out to the public so that they they kind of get sensitized towards eye examination of kids, of adolescent people and so on. So that is where this film idea came up, you know, and of course it was Yashwant's support to get Mr. Nitin Gadkari. Without him, I don't think we would have, you know, got such a big person in, and I think that actually.
So it took a big person in optometry to get another big person.
Absolutely, yes, you're right.
Okay.
You're right. Yes. So I think that is where the idea stemmed from, in terms of, you know, we need to make this this kind of an awareness film. It needs to be short so that people don't get bored of seeing. It needs to have key messages.
It has to be crisp and yet, you know,
I think it was an entire team
informative
effort.
enough and yet crisp. Yeah.
Absolutely. So, of course, Anuradha and Rizwana, who are part of the task force, are not here today. Yeah. So it was absolute team effort and, well executed by each one of them.
Awesome. I saw the film. I really liked the film. It looked very neat, very professional and very crisp. Now the film is out there. I think people, all the optometry fraternity, probably eye care fraternity liked it. What is next now? What are you going to do with it?
So now we want them to use it as much as possible. So the reason why we made this film is, in every optometrist clinic, when they see a myope or in the waiting area, or when they see that the parents are myopic, you know, make more and more people actually view the film. And that's one of the reasons why we got it translated in one language. Of course, we are looking for support to get it translated in all the regional languages also. If we can do it, nothing like that. So the more the viewership, the better. It is not in terms of, you know, publicity for OCI or anything like that. I think the objective is very clear for all of us here as task force, that we want the awareness to be at the maximum in terms of people really understanding that this is an issue. See, even today, if you look at being a private practitioner, I'm sure Yashwant would agree. It is like, why me? Mujhe kyun chashma aaya? That's the only thing that they are really concerned about. It is not that, okay, going forward, how is it going to affect me?
Right.
How do I really prevent the increase in myopia and things like that? So that is not there. First of all, acceptance is an issue. Second thing is to actually make them understand there are methods to control, and that is what we're really looking at. So now we know that you have a problem. How do we really control the increase in myopia? I think that's the bigger picture all of us are really worried and concerned about. And just to give you a small incident that just happened a couple of days ago. So we had a school screening for the underprivileged in Mysore.
Okay.
And the first patient that was screened, one eye -6, the other eye plano. So just imagine, and the kid was absolutely clueless.
Unaware.
Yeah, absolutely unaware. And this was all girl. It was a girls' school. Okay, and few of the others who were screened, they refused to even select the frame because they were that taboo of wearing spectacles.
I know.
And they were all underprivileged children. So they needed support if they wanted to go in for contact lenses or something else. So it's still there. So the issue is just not even, I feel that we are just touching the tip of big
There's
issue.
a lot of work that has to be done, all of us collectively.
Myopia and myopia correction. It is not as simple as that. It is a real huge issue that we are dealing with. It is socioeconomic.
Yeah.
It is cultural. It's all of that put together. So the person really had to speak and convince the girls, saying, you're going to benefit with this. It's going to benefit in your studies and all of that, because they were just point blank saying, I don't even want to wear this. So why are you asking me to select a frame? And that too, we were giving it free of cost. So it is at that level is where the issue is.
Good. I think we've got a bit of understanding, and we know what we are going to do next. I'm just going to move across now for the next round of questions, and I think I'll come to Yashwant with this one, because you are the private practitioner here, Yashwant, and I can understand being in solo practice, certain things can be challenging. And being the first mover, you have your own set of challenges. So as a as a optometry private practitioner, did you have to invest a lot in making your clinic as a myopia management clinic? What are the challenges you face, and how did you overcome those?
Well, in the question itself, you gave the answer, Nilesh. When you say optometry practice, now if you have an ideal optometric practice, about 95% of what you require for myopia control is already there in your clinic.
Right.
You just have to use it. Right, barring the two equipments which are like corneal topographer and maybe axial length measurement instruments, I think every optometry practice would have everything that is required for myopia control. So in the initial phase of your practice, you may not spend money on these expensive instruments, and you can always outsource these things. Initially I used to refer my patients for corneal topographies outside, and actually it helped me, because when the ophthalmologist realized that ortho-K lenses are working, I started getting referrals from them. So all those referrals have now reduced because I've got an in-house topographer. So sometimes I wonder, if I start referring the patients back to ophthalmologists and let them see that ortho-K is successful, would the referrals increase even more? And many a times, the cost of these instruments is intimidating. I would request all the optometrists not to consider the cost at one go. I mean, there are nationalized banks which are willing to give us at very attractive rates of interest for medical professionals. And you just calculate the EMI and ensure that you're able to pay off that EMI, and you can have your own instruments. I was lucky enough to have a A-scan since last 20 years, and I use that instrument for screening, because we all know optical biometer is more accurate if we need to follow up the patient, but for screening, A-scan is very useful. So I would very happily say that my clinic now is complete. But as I said, 95% of all what you need is already there. You might have to spend some extra money in terms of, buying subscription for ortho-K designing softwares and a couple of more softwares, but that's about it. Nothing is too expensive.
So more than the
Very easily
instrument, I think
possible.
is the mindset of the clinician that has
Exactly,
to
it's
change,
the
right?
mindset. And I liked when Lakshmi and me were having a discussion. It's not about doing all that 95% in all of the patients. At least make a start. Start with counseling. Everybody can
Exactly.
counsel the patient, and then gradually build up on the practice. It's not like today I'm going to have 100% successful myopia control practice. That's never going to happen. So at least make a start.
Cool. So a similar question to both of you. Maybe Vishwa, you can answer from the hospital point of view, and Pawan, you can talk about hospital and research both point of view. Your clinics, I mean, how are they different from a typical, private practitioner's clinic? Your, views on that.
Yeah, I think I completely agree with Yashwant. See, when, as I said, about 4 or 5 years ago, before that, we had myopic patients and we were not really documenting any of these, including the axial length. We felt the need, so we got those equipments. But I think the most important point that I think we have to understand here is, what is it that you want to do? Suppose you want to understand the efficacy of any of these strategies, then probably you need to have, for example, biometer,
Right. Yeah.
because you want to understand what is the axial length before and after, whether is it working or not. So if you know what is it that, if you know the purpose of this, then you can decide. If the purpose is to understand the efficacy part of it, then yes, definitely you need to invest on these equipments. It is recommended. I'm not saying that it is mandatory to have a biometer, okay, to start with at least. Okay. Similarly, if you want to, really follow patients of your ortho-K or any of the, anti-myopia strategies, yes, definitely, ocular biometer is required. Otherwise, as Lakshmi and Yashwant said, for myopia management, you can in fact start off with a plain counseling, talk about lifestyle changes and things like that. So that's what we are doing currently.
So I think that's a good news for any youngster or any practitioner who's thinking, what do I do next? Do I have to invest 10 lakhs rupees or so on? I think we can start today, not even tomorrow. You can at least start with counseling and start with the basics things. And as Yashwant started with referring his patients initially, and then probably once he was sure, he would think of, buying his own equipment, etc. But there's no reason for us to wait. That's for sure. Lakshmi, you want to say something?
Yeah. See, initially, I think all of us as optometrists, we knew there was myopia. We knew there was progression. As private practitioners, we used to say, when we diagnose myopia, we used to say you need to come for regular checkups and leave it at that, right? So now it doesn't end there. You have to make sure they come at least once in 3 months for a checkup. You make sure that you have told them that this is going to increase,
Right.
and what are the options available for control as private practitioners. So there is a lot of role that as practitioners somebody has to play, and you need not.
I think Enzo also agrees to what you're
Also
saying.
agree to what
We
you're
agree.
saying.
We all agree. We all agree. So I'm just coming to Pawan. If you want to add something, Pawan, or you're okay with this?
Yeah. So one of the important things that we need in myopia management, I think, is the confidence. So like Yashwant pointed out, well, somewhere you need to start, but if you're ready, I think you don't need any extra instrument to start myopia management. Whatever you have in your hand as an optometrist, you will have retinoscope or autorefractor, you will do subjective refraction, you will assess the visual acuity, you will take a bit of history. Brilliant. I think this is good enough for us to really jump on to start myopia management. I'll just take a couple of extra minutes, Nilesh here. So I was looking at a model to see how many parameters do we actually need to really understand if somebody is at risk or is at no risk for myopia progression. So we build model with one factor, just change in refractive error, to comprehensive, very holistic approach, 10 factors, including the time indoors, time outdoors, time on reading, peripheral refraction, lag of accommodation. So we took at multiple factors.
Right.
And based on the very vigorous analysis, we found that you need minimum of 4 variables to really understand if that kid is at risk or at no risk. change in refraction. You get, even if you're seeing patient for the first time, you will assess it based on the prescription that person is wearing, if there is a change or not. Since both parents, what is the myopia status? That will help you to really understand. Current refraction, is it really -1? Is it -10? So you need to know that as well. And at what age are you seeing that kid? Is it 7 years or is it 17 years? I think these are the minimum factors that will really help you to understand or get a big picture going.
Right.
Now, all the sophistication of peripheral refraction, the non-contact biometer, or whatever extra things, lag of accommodation you want to assess, that will help you in deciding the management plan. If you have, it's good. You know, okay, there is a defocus of this much amount. Yeah. Okay, I know the lens is this much, the cornea is this much, or the actual length, is it correlating or not? So I think as simple as a regular optometry practice is sufficient enough for us. And like Yashwant already pointed out, you know, the non-contact biometers are great. It has a very high resolution, but the ultrasound will really help you to understand what's the status. I mean, you will pick it up if it's 26 or 24. The difference is only 100 microns. So I think that will really help you even for getting the follow-up measurements. If you're seeing the kid in 6 month time or 1 year time, if you look at the change of, let's say, half a diopter, and you're looking at change by good 0.3 mm corresponds to 1 diopter on average, let's say. So that will be picked up by ultrasound anyway. So we don't have to really look at fancy or the expensive ones as well if you want to jump on and start.
Right. So you need to look at the practicality of the situation, right? I think you're talking about the paper which you recently published, is it, where you challenge the lag of accommodation theory? Is it something you're talking about?
Yeah, that's to do with the screen. Is it always the screens or the reading?
So see, I was just trying to flaunt that I also read.
Yeah, thank you.
Anyway.
This one was a review of myopia. Yeah. It came in review of myopia, I think. I'm not sure. I just read.
So in that.
So now Lakshmi is also flaunting.
I just read it.
What we were indicating is, well, do not blame the screens alone. I think, you know, a lot of people develop myopia even before there is mobile phone in hand, even before there's laptop available.
Correct. So I think we'll take a little pause because there are a couple of questions on the Facebook and I think they are relevant. So let me take the first question. It's someone, Shivasai Venkatesh, I think, has asked, what are the factors affecting before COVID and after COVID for increasing the percentage of myopia to around 15% in the kids, as you said? So maybe Vishy or Pawan, if you want to take up. So pre-COVID, I think post-COVID, myopia incidence has probably increased. So what could be the factors?
One big thing is, because of the lockdown, all of us, are using gadgets in some forms. Either it could be mobile or laptop. All of our screen time has increased drastically. Okay, that is one. Second thing is, I think, people are not going out. Okay,
because lack of
outdoor. So these two are major factors. And the other thing is, see, when people are using these gadgets, especially mobile phones, it is the distance at which that they view things. Either it could be online classes or without frequent breaks, or at the distance at which they view either other games or other things, other social medias. So these are some of the factors which definitely are causing are the reasons for the increase in the percentages.
Right. So Pawan, you agree or you want to add something?
Absolutely. Endocentric lifestyle, less time outdoors, too much of near work, triggering for a lot of accommodation.
I completely agree. And that's exactly why I had to take my family on vacation, all kids. And, we had to go to Goa, man, just to show them.
Nilesh, but I have a question here. I mean, generally what I understand from the researchers is once the myopia sets in, then the role of outdoors is questionable. So if that is true, then the endocentric lifestyle, how come it is contributing an increase of myopia? I agree, near work, that is fine. But why lack of outdoors?
Yeah, I think that is not good point, Yashwant. So clearly, like you said, time outdoors is protective for myopia. So it will help in prevention of myopia or will delay the onset of myopia. Various studies have indicated that if somebody is already -6, I mean, you go outdoors for 3 hours, 4 hours, doesn't matter. I think something is already kicked in. The effect is definitely less. Like you said, I think the point is, well, you're not going outdoors, meaning you're indoors and doing something that's close to your eye. And a lot of accommodation, mechanical stress, that could be the factor to look at.
So there's a question for Lakshmi, I think.
And also maybe vitamin D, Yashwant, just to, we don't know what role it plays, basically, I guess, dopamine and other effects also, because of you know, less of exposure to sunlight outside. And even now with the schools and all even opening, I don't think the physical activity has still gone to pre-COVID times. You know, they're basically looking at how do we cover the portions and, you know, get back to the study routine, but the physical activity routine has still not gone back to pre-COVID times. And I think this is going to be a cascading effect because of less of exposure to sunlight. It is not just myopia. I think we're going to have a whole lot of other issues
as well,
related to this as well.
So Lakshmi, I'm asking you specifically because this is at a larger scale. So the question is, what are the current steps to tackle myopia progression by GOI, NPCB, etc.? So it's a much larger question, and that's why I had to ask it to you.
They are emphasizing more and more on regular school eye screening. That is something that's come from the government point of view. But specifically related to myopia progression, we really have not seen. But we as task force are trying to push, you know, in terms of the white paper that we have submitted to the government, saying that, you know, outdoor time has to be made compulsory and all of that. I wouldn't really blame them, Nilesh, given the time frame where all of this have kind of cropped up in the past couple of years, and because they have a bigger issue of COVID to deal with and stuff like that. So I'm hoping that, you know, maybe next year we will see something specifically related to myopia.
I think launching the myopia
Not
film.
to say that I belong to any party or anything like that. I'm just, or I'm supportive to the government. I'm just saying that, you know, generally, I think there are bigger issues, but we have, I think, even Vision 2020 on their part, and all the others are trying to bring to the attention of the government that this is a big issue. You know, it is not just wearing glasses. It is definitely a larger issue than that.
Yeah, and I think launching the film, being involved in launching the film was probably one step. So before I take, you know, our question, there is just a comment from Hamza, and I'll just read it out. I think it is quite an endorsement to what all three of them were saying. He says that I started a couple of years ago with basic counseling, and I feel staying updated with recent advances and technologies is a must. I think that's a very important point. Stay updated because, you know, the science is evolving. We are also learning every 3 months, something new comes up, some new either endorsement or challenge to previous theory, right? So practically involves zero cost. At least we can pass on the available information and let the patient decide what they want. So thanks, Hamza, for those for that comment and endorsement. And others, please feel free to write your questions also. So guys, I have one more question for you, and I think this would be a question in other people's mind as well. So, you know, as myopia management, I would say, practitioners who are doing myopia management, what are the various options that you're offering currently to these kids? Anyone can start first. Your take.
Anyone, no one would speak.
That's I was just checking that. So maybe Yashwant, you can start being in private practice.
I think the first option that all of us already have is refraction. We forget refraction. We just need to make some changes to the refraction. Do your MEMs and do your AC by A ratios and PFEs and FE, all those things need to be done. So it all starts with a good refraction. Then you've got option of orthokeratology. You've got option of spectacle correction for myopia control, soft myopia control contact lenses, and binocular vision. So binocular vision is something that people tend to forget. So with all these options available, I think more or less everything is available in the Indian market today, and we complete our what do you say, arsenal for
Portfolio?
myopia management.
Okay. So you mean to say virtually whatever is available in India, you are
That's
currently
all
offering
about
all
it.
of
You
this?
don't need anything beyond that. It
Right.
is just, you know, in one particular option, you might have 10 companies,
Something.
out of which about 2 or 3 are there in India at present. But
Okay.
option wise, I think India has got all the options now.
Okay. So in every category, we have at least some products. That's what you're saying.
Yes, definitely.
Good.
And
What about
also co-management with the ophthalmologist in case, you know, they are on low dose atropine and things like that. So we do have a few
so
patients.
is it? Do you mean combination therapy?
Yeah, combination
Okay.
therapy. So we are looking at that. I mean, as a private practitioner, wearing my private practitioner hat, we do work with a few ophthalmologists who who prescribe low dose atropine. At the same time, they also send them to us either for orthokeratology or other options for combination therapy, because they are young kids and there is a possibility of aggressive, you know, where the myopia is quite aggressive in terms of progression. So we do have combination therapy as well. So I think, as Yashwant said, multiple options are available. And I think as optometrists, be it institutions, be it private practitioners, our duty is to just lay all of this in and say, you know, these are all the things that you have. So you can, and the decision is not to be made right there, right now, kind. You know, take your time, do your own research if you need to do it as a parent or as a you know, kid, adolescent kid, or whoever is the person, and then, you know, think about it and come back to us as to what you feel is you know, better. Because you know, it's very easy for us to say that these are things and, you know, you can choose, but for them to accept that, you know, it's not as simple as spectacles, but it is bigger than that. That it
might take a little longer for them
and
to take a decision.
Yes.
Yeah, Yashwant, you're saying something?
Yeah, Nilesh, in the initial stages of my myopia control practice or even optometry practice, I used to leave the patient at that. You know, you think about it, do your research, and then come back. But I think later on, I realized that I was making a mistake, because 90% you have counseled the patient. Later on, you have to call the patient up and help them to reach a final conclusion or show them the way forward. You know, that is something that I was missing initially. And I actually missed a lot of patients because of that.
So after you're doing that, are you seeing a difference in the number of patients coming?
Huge difference, huge difference.
So I think
because,
that's
you know, when you
thing.
give 10 options, the patients are confused. And the typical reaction is, you know, let me go home, think about it, and then come back. And the patients would never come back.
Yeah,
so
because
you tell them
to us
research.
also it is so confusing. I can imagine to a layman.
So give them a reason why you're selecting one particular therapy or a combination therapy, and then you win the patient.
Okay. What about you, Vishwa and Pawan, in terms of the options that you're offering? Anything specific? Anything is your favorite, or anything you think has worked better than the other?
Yeah, there is no favorite options actually. As Yashwant said, we give the options to the parents. Parents obviously would question us about what would work. You suggest what is the efficacy for my son or daughter. You explain. So you explain about these. As Yashwant said, if you give too many options, also they get confused, no doubt. But one thing we don't give combination of treatments at the very first front. We don't do that. If we start off with one, we try to monitor their progression in terms of cycloplegic refraction as well as the axial length before and after. And the majority of it, see, to start off with, when we started in 2016-17, we started off with pharmacological one. And we started off with low dose atropine. And what we realized over a period of time is about 80% of them, it worked. There are some people for whom it did not work. See, they are non-responders. So this is where, we need to intervene and then understand why is it is not working for some. Okay, whether for them, what do we do? Should we consider increasing the dose, or should we consider some other or combine other treatments is what we should think. this is where, a lot of effort now is going on to understand what would work for these kids. Okay. Otherwise, I think there is efficacy in each of the strategies,
Okay.
and there are literatures are very clear about these, either a spectacle or ortho-K or low dose atropine. The efficacy is, say, people say in percentage. There is a big debate on to use whether percentage or not itself is a
Or
debate.
diopters.
Or diopters. So I use percentage to explain to parents, but
Okay.
scientific thing is different.
Yeah. So in your mind, you're thinking differently,
Yeah.
and you're telling patients in their language.
Yeah. So this is what we do here.
Okay. Pawan, anything to add?
So at LVP, we use environment strategy as first line of the anti-myopia. If there's nothing much, so we just say, well, less time on the rear work, more time in outdoors, and the set of guidelines. Then in the pharmacological management, obviously the 0.01% in consultation with the ophthalmologist, obviously. And in optical strategies, we do go with the bifocal or the peripheral defocus lenses, the spectacle format.
Okay.
In contact lens, again, ortho-K or the center distance design or EDOF design. So these are the various. And at times we combine depending on the need, like Vishwa has already indicated, depending on the need, we jump onto the combination strategies. Yeah,
Okay.
but again, we also narrow it down to, okay, these are A, B, C, D options. Like Yashwant said, we want to go with this, given that A, B, C reasons, and then leave it out for 10 days or 1 week. They let them do the research and come back.
Okay. So just for my curiosity, actually, because contact lenses, do you guys also do multifocal contact lenses for myopia control?
Yes.
Soft lenses, I meant.
Yes. Center distance.
Center distance, you do. Okay. Yashwant, you also doing?
No.
No. More of
Because
ortho-K, is it?
when you have specific myopia control, soft and RGP contact lenses both, why multifocals? That is how I think.
Okay, good. So before moving forward, I think there's a quick question I'll take again. I think it's Hamza again who's asking too many questions, but I think it's a good question, so I'll take it. This is about myopic patients in 20s, so more like adult myopia. So if the progression has not halted, do we go ahead with regular protocols or any other approach?
The question is, if somebody is adult and then there's still myopia.
Myopic in 20s.
Yeah, so that's quite possible. Yeah, that's quite possible, and we do see this, especially if somebody is already a high myope, -10s and -12s, they would still show some progression when the parental history is strong. 20s or 30s doesn't matter. You would still want to put them on some anti-myopia strategy if you know that there is clear change in action.
Okay, so your strategy will be similar to a child, a myopic child. In your mind, the strategy is similar.
Yeah, age is not the criteria.
Age is not a criteria.
Yeah.
Okay.
If there is a progression, there is progression.
Yeah, I think that answers the question. I'll take another quick one. Is there a role of vision therapy in myopia management? Can it be of any effect?
Yes.
Okay.
Yes. Especially some kids, who've got lag of accommodation and they are ESO4s, they are at a high risk of developing myopia. So definitely, I personally believe, whatever is wrong in terms of binocular vision, that needs to be corrected first, and especially if there is lack of accommodation.
Okay, so there is a role in specific cases.
There is.
Okay, good. Now, the most important question, I think, a very practical question that all of us are facing, maybe private practitioner probably face more. And the question is, how do you counsel your patients and parents? It's so difficult for them to understand and, to put them on a therapy which they've not heard before. So, kaise karte ho ye sab? Maybe I'll start with Vishwa first and then I'll come to Yashwant this time.
Yeah. See, what we do, it is easy for a parent to understand a myopia correction. But when it is beyond myopia correction, it is always difficult for them to understand these languages.
Correct.
See, there are a lot of these infographics, brochures available to make them understand what exactly we are doing. See, communication is very, very key in this. If we don't spend adequate time to explain to them what the kid is going through, I don't think they will, comply with whatever we tell. Okay, the efficacy may be great, but if you don't comply to it, what is the point? So I think communication plays a big role. So how do you explain the myopia correction to a treatment or control is very, very key. Maybe use some images, especially in a tertiary hospital like ours. There could be even as trivial as language barriers.
True.
Okay, whatever we tell, they may not understand. So I use a lot of these infographics to tell them what exactly is going on with, you know.
So you have posters and printed material.
Tell them, explain them, give them case scenarios. Suppose you don't correct them now, what will happen to the kid next year? If you treat them, probably may happen in the subsequent years. So give some examples to make the parent understand. Also, as Pawan said, we also talk about these lifestyle changes, how to take frequent breaks, and the importance of spending time outdoors. So these are some of the things that we tell every patient. We give them a small brochure. In fact, I shared that with Lakshmi to be circulated to all the optometrists.
Great. So before I move across to Yashwant, Pawan, if you want to add something to this point. Counseling, any key messages that you have in your mind?
The only one point that I want to add on top of what Vishwa said is give more time. This is not the easy goal. It's not like prescribing this spectacle and everything is understood. So it's not the case with the myopia management, because first of all, they're expensive. They have to understand. They're worried also that there is progression. So I think looking at the not just myopia, but the person, I think we should give more time to explain what is this condition, what is happening, and what are the anti-myopia strategies, and leave them with some information. That's what it is. So I want to highlight that don't look at the condition, but look at the person. And then keeping that in view, just talk more and then explain, ensure that they understood the story.
Okay. I think, Yashwant, probably you might be facing this challenge because being in a completely private setup.
Yeah, actually,
or you
Nilesh,
don't.
I was just thinking, these two guys, not to undermine their efforts, but these two guys are like Arjuna, who've got a Krishna behind them. Shankar Netralaya and LV Prasad Institute. Things are pretty different for me and Lakshmi.
In private practice, they are different.
Patient,
you are like Bahubalis on your own.
on my own. So initially what I did when I started orthokeratology in 2006, I invited all my potential patients to a nice place at Nagpur, and we had a breakfast meeting, and I told them about what ortho-K was. And I thought, eventually patients would get converted into ortho-K, not one got converted. So that exercise was a complete waste. So then later on, we modified that. We conducted the same kind of exercise, but this time I got an external speaker. So Dr. Nitesh Barot had come from UK.
Right,
so somebody coming from UK, an expert in orthokeratology, it had that desired impact. And on day one, about 7 patients converted to ortho-K.
Oh, cool.
So I think this has really worked in my practice. Group counselings in the clinic, 5 families. So if one family wants to understand one particular point, but is too hesitant to ask a question, the other family would ask a question and all would benefit. So group counseling also has helped. But what has really helped in my practice when I do one-to-one counseling is the axial length measurements.
Okay.
So you show them numbers. So today your child's axial length is this, the age is this is the average progression of your axial length. So if we go by this math, by the time your child is 21, he would have crossed 26. And under no circumstance we want him to cross 26. So that really hits the bullseye.
Okay, I think that's an important takeaway message, because we want to know what really works. What are the top messages, right? 2 or 3 key messages which are hard hitting, and an average optometrist can use. So axial length, something that works.
Nobody can deny it. I give a report.
It's there.
So nobody
it's hard.
can deny it's a hard evidence.
Okay, Lakshmi has
just to highlight.
Like Pawan is itching to say about
Pawan, go ahead. Go ahead. Let Pawan speak first.
Like the LVPI and Shankar Netralaya, I think Yashwant itself is a brand by itself. He himself is a brand.
Yeah, so Saoji Vision Care should be enough, right? Yeah, Lakshmi, you were saying.
So Pawan, it's blessing of Shankar Netralaya and LVP.
Oh, he has got both, best of both worlds, actually.
Yeah, you people don't have that.
Yeah, Lakshmi, go ahead.
No, I just wanted to say that, initially, just an example of a case that we had. So initially, when we explained, the person whom I'm talking about is now in 8th standard. She was in 7th standard earlier, 6th. She had just passed her 6th or was in 7th. And then when we explained to the parent was a bit hesitant in going for any of the myopia control strategies. And of course, then COVID came and all of that. And then they knew that the power had changed because the girl was saying that she can't see clearly. Okay, so post-COVID, when everything opened up just recently, a couple of months ago, they came for a checkup and they knew that the myopia had progressed by 1.5 diopters. So 1.5 is a huge jump, So, and then they kind of said, okay, let's look at what are the strategies that we have. What can you offer and what can we go in for? So there are cases like this as well. So in the sense, as Pawan said, economically also we have to consider all of that as well. Although people might say, oh, it is health, people have to spend and all of that. It's not as simple as that.
Still it is paying money, right? Harder.
Not even that. It is something, although, you show the numbers and all of it is something that they think that anyway, he has a problem. You're giving the correction in terms of spectacles. So what is the issue? That communication needs to go through very clearly, because this is treatment, but for control, there is something different. Okay. So that's, I think that very importantly, what Vishwa touched upon, it is very, very important that you keep these two separate and explain to them.
Awesome.
Giving glasses is treatment for the current issue, but there is a different issue and you have to deal with that. And that is what is progression, and that will happen. And these are the different options. To digest that, it does take time. So for this person, they experienced it, then they came back, and now they are on myopia control measures. So these are the learnings, I guess. With each patient, you tend to learn how to address these issues.
Cool.
Nilesh, just a quick comment in continuation to my answer. I'm glad Pawan mentioned about the ultrasonic A-scan. I have two patients. One girl is about, I think, 16, and she is minus 6.75 with some astigmatism. And all along, I've been counseling her for myopia control, and the mom is a homeopathic doctor. She never really agreed to it. And I was actually losing my patients because minus 6.75, I was worried about the girl until we measured the axial length, which was like 24 point something. And I have another case, I remember the name also of that patient, -2. So I said, it is important we put your child on myopia control, but maybe we can keep a watch for about a year until we did the A-scan, and his axial length at 14 or 12 years of age with a -2 prescription was 26.1.
Oh my God.
So again, A-scan, axial length, very, very important.
Very important.
And I'm very happy that companies are coming up with instruments which has got dry eye measurements and corneal topography and axial length measurements all bundled
in one. Wonderful. I think that would be great help to the clinicians. So Soumya is saying, Vishwa sir, can you share the infographic, please? I think it's with OCI, right? So OCI can
we'll send it to all of us.
And I think there's one comment. Let me just go. Sanjay Tiwari ji from Hoya, and he says that there is a need for mega strategy at a national level by taking all stakeholders together so that this myopia pandemic can be addressed comprehensively, especially keeping in mind the kids who are worst hit and they are our future. I think we all agree to that. And OCI and Myopia Task Force members are doing a great job. It seems ECPs are doing it individually, but looking at the enormity of the challenge, national level mega strategy is required, I guess. And I think Hoya also supported the myopia film, right?
Yeah, it was through their support that both the fields, the Hindi and the English one, was there.
So I'm sure, Sanjay ji, I think all of us agree that we need a consolidated effort by all of us put together. It's not going to happen with individuals working in silos. It has to be a group exercise. Now I'm coming.
So Sanjay, a message for Sanjay. We will keep working towards it. You keep blessing us.
वो तो आता ही रहेगा सर, आप बस अच्छा काम करो ना. So this is a very specific question to Pawan before we probably end in next few minutes. See Pawan, as a researcher, because we an average optometrist or a practitioner always thinks that research is not for me. It is for, the angels like Pawan and Vishwas who are in institutes and who are the great researchers and scientists. So I just want your opinion on that. Can an average practitioner contribute to this?
Thanks for calling us angels, first of all.
Because you're giving us all the knowledge and information that we need, right?
It's important that we listen to people from both the East and the West. But sitting right in the middle, I think our ethnicity is different. India stands different in terms of many things. Our environment is different, our food is different. Whatever you call, I think we stand a bit different. In terms of anatomy, we look a bit different. Ocular anatomy is also different. All I'm trying to say is, in India, we don't have too much of data coming out, unfortunately. So to this, everybody can contribute and every bit counts. Now, whatever data you have, as I said, you don't need 10 factors. You don't need too fancy stuff, whatever you are doing in your clinic. If you can put that out as a case series or case report, I think that will still add to a lot of weightage to the Indian myopia scenario, I think, which is very important for us.
So you would encourage everyone to contribute in whatever they can?
Absolutely.
Because I think this is where probably we are struggling, that we don't get enough data from practitioners. And I think if practitioners also start thinking on that line that, we as an individual, I can also contribute. It's not a job of only tertiary institutes. Everyone can contribute. I think we will change the entire scenario.
Research can be done at multiple levels. You can just saying that research can be done at multiple levels and multiple ways. So you pick what is really convenient to you or what you can do with your own resources.
With the setup you have, yeah. Yashwant, you were saying something?
Yeah, I was saying that initially when we started orthokeratology and not orthokeratology, myopia control, we did not have a standard protocol. So I got one of my interns to design a protocol and I circulated that protocol all over the world, all the myopia control experts around the world, got inputs from them, modified it, and this cycle happened 2 or 3 times. So I've got a complete, well-designed myopia control protocol.
Lovely.
So if all of us can follow one protocol, it will become very easy for guys like Pawan and Vishwa to actually collect the data and give us so much of information.
Awesome. So I think first step is done by Yashwant and his colleague, that we at least have a protocol which all of us, a standard protocol that all of us can follow. Good. So we are just about to close, last few minutes, but I think I'm not going to leave you without just one simple question. What's your message to all those who are listening here, which is relevant to today's discussion, myopia management? Maybe Vishwa, Vishwa is starting.
Yeah, maybe. So I think the most important thing
Vishwa was offended because we did not call him handsome. So Vishwa, go.
Thank you for that, Nilesh. I think the important message that I want is start somewhere is what is very, very important. I think go beyond single vision lenses, which means start thinking about it and convey what is available in India. So at some point, people will definitely consider, some of these strategies at some point.
Cool. Yashwant.
Well, I would say long journeys begin with a single step. So take that step. And, often we make fun of WhatsApp and Facebook universities. But if you join one of these courses, I tell you, there is so much of Gyan in Facebook and WhatsApp universities. You should know which to pick.
Yeah, you should join the right ones.
You should join the right ones. I mean, all what I understand is courtesy Facebook. There are excellent groups on Facebook. I think all of us should join that.
Great. I think
so
by attending
Vishwa said,
this,
make a start.
And by attending this session, probably they have made a start. They just need to build on this. Pawan, your message?
I was thinking you will say handsome again, but yeah, thank you.
that has gone to Vishwa now.
Okay. So I think the message is the confidence is contagious. So start somewhere and then start building it up and then spread it across. Indian ethnicity in terms of the myopia scenario, I think we need a lot of data. We need to start somewhere in the research front as well. So every bit counts and everybody can contribute is what I want to highlight it again. Thank you.
Cool. And Lakshmi, that's not just one message for you. I have another specific question for you, because you're at a position where, you know, you are connected with so many optoms. So what's your plan to enthuse all these optoms?
Enthuse the optoms, I think, see.
Of course, in today's context, we are talking about in myopia management.
Yeah. So one is, if we can post a link of the film on Facebook, which I think we'll be doing, try and use that as much as possible to spread the knowledge of myopia to your patients. You know, not only those who come to walk into your clinic, I'm sure all of them must be having their own database also. So make sure even people who are not myopic, even for the geriatric population, because then they will have grandchildren and all of them at home. Just that for them to be aware that this is something that is happening, and you know, we have to get our eyes checked regularly. So that is something that I would request. And second thing is, you know, we always have been saying, oh, optometry is neglected in the country. Optometry profession is, you know, not given the importance. This is your chance.
Yeah.
This is the golden opportunity that's come in front of you to rise up to the occasion, stand up and say, I'm going to make a difference. I'm going to make my mark when it comes to myopia management. So I think that should be the motivation. I mean, there's no other motivation that's required, right?
And
so,
I think that is also your message to the optometrists who are listening,
yeah,
right? That this is your chance. This is your final match. This is where you hit the sixer.
Exactly. So don't complain saying, oh, you know, every Tom, Dick and Harry does refraction. Spectacle can be prescribed by anybody. Well, you have to rise. You have to do a little bit more than that. And I think that is the encouragement that I would say. This is your opportunity. Don't let it go. I think this is something that we need to have our stamp on. And yeah, I think that's the way to move forward and put in. I think, as I said, you know, as even Pawan said, research and data is not that you need to have one lab. You need to have, you know, somebody weird looking person with, you know,
or handsome looking,
doing the research and stuff like that. It's not.
Yeah.
I mean, you know, there's always this block saying, oh, you know, research is something that is not for me or whatever. It's too difficult and stuff like that. I think every bit of data counts. Even if you just do a retrospective analysis of all your patient records and see how much % of them are myopic, and then maybe call them back and see whether it's progress. That itself is data. So, and that is what is lacking as far as we are concerned. And we need every bit of that. Every bit of that data counts. That's what I would say.
Awesome. So I think that brings us to the end of this very engaging and very absorbing discussion. I think I just want to thank everyone. Good to see you guys. Good to see Yashwant, Vishwa, Pawan, and Lakshmi as usual. Let's hope that all of us together can enthuse more and more optometrists to do their job well. And I think myopia management is a good tool. It's a good weapon that all of us have in our kitty to just stamp our authority in the eye care field.
Yeah.
On that note,
the link of the films on Facebook, so people can go there and then watch the film and use it. It is free for all. So, and that's the reason why we made it in such a way. So please
make the best use of it. Use it freely and circulate it among your patients. It's not for optometrists alone. It's actually for patients and parents so that they understand what myopia is. On that note, have a lovely evening, guys. Enjoy your weekend. Take care of yourselves and stay safe.
Bye-bye.
Thank you.
Thank you.
Yeah, thank you. Bye.